Um, so again, my topic today is, as the title says, is acute hospitalization for people with dementia. And I really want to emphasize the part that I think it's important to view this as a bridge and not a gap. I cover a number of different settings in my work. So I cover our inpatient long-term care nursing home unit. I also work in geriatric medicine, and so I also work in the outpatient geriatric medicine clinic. I do a lot of individual work, couples work, group work, involved for people with people who have dementias, as well as caregiver work. And so have an opportunity to see sort of the spectrum of care and see admissions occur, see people who are coming out of the hospital after admissions. And just this is just something I've kind of backed into over, I've been doing this about 20 years. And so just backed into over the course of this time, which is if we view a hospital admission as somehow a failure, then we set ourselves, and more importantly, the patients and their caregivers, up for a different outcome in some ways, versus if we say, well, it's time to do something different, it's time to do something a little more intensive, and view this as a bridge to coming back to being home again, for example, and being more successful there. So by way of quick disclosure, I am here just to present my own ideas and opinions and insights. So I'm not here officially in any way to represent the VA, University of Washington, Pacific Lutheran University. I don't have any other disclosures though. Also though, just by way of a disclaimer, I'll present a lot of information that's intended just for general educational purposes. By no means would I ever want to take anything that I say and present it as something that should substitute for the clinical judgment of treating providers. Certainly the clinical decisions are the sole purview of treating providers. So I'm purely here to provide information and not guidance. I wouldn't want to make anyone feel cornered in that way. So by way of introduction to the topic, I will just throw out a quick rock chalk Jayhawk. I am in Tacoma now, but for many, many years worked in rural mental health, small towns, and that includes a long time in the state of Kansas. I went to school in Kansas. And so I'm a Midwesterner, and I really appreciate the chance to be back in the Midwest, even if virtually. So I'm going to be talking specifically, and you'll hear me use the term major neurocognitive disorder, which is the current most updated term for what we used to and still do refer to as dementias. The DSM-5 TR system has renamed it major neurocognitive disorder. And that primarily was to deal with the stigma that came to be attached to the term dementia. So cognitive changes actually occur across a spectrum of severity and type. I won't go into the different neuropsychological changes that are involved, but there are a number of neuropsychological domains, some which change with age normally, some that don't change even with age. And so the assessment and evaluation of cognition change involves a lot of work to rule in and rule out pertinent factors. For example, getting dementia labs, head imaging, etc., neuropsychological testing. But what we want to do is separate someone who's having normal cognitive changes from someone who might be experiencing changes that are beyond what we would expect for age, but that are not severe enough to impair functional status. And we currently refer to that now as mild neurocognitive disorder. Used to be called MCI, or mild cognitive impairment. But the focus of this talk is really on major neurocognitive disorder, what we call dementia. And these are significant changes that are beyond those associated with aging alone, and that are resulting in functional changes due to changes in cognition. So not, for example, changes in mobility due to peripheral neuropathy, but changes in function that are specific due to cognitive function. There are multiple etiologies for major neurocognitive disorders. The one that most people are commonly familiar with would be Alzheimer's disease, obviously, which gratefully we have the Alzheimer's Association, which does tremendous work. And I've had the opportunity to work with patients who were, many who were also receiving support, and their caregivers, excuse me, through the Alzheimer's Association. And other types of etiologies, though, for example, can include Parkinson's disease, amyotrophic lateral sclerosis, frontotemporal dementia is what used to be called Pick's disease, prion diseases, vascular neurocognitive disorders. So there's a whole host of things that can cause these. And so I provide this information just as an orientation into the topic. 2 key points for inpatient staff being cognitive changes don't necessarily equate to dementia. They may, but they may not. And not every form of dementia or cognitive disorder is Alzheimer's disease. And these different etiologies present differently neuropsychologically. It's like getting a set of lab values on neuropsych testing, and different disorders will present with different values, elevated or depressed. And this will come into play more extensively as the talk goes on. So what are we looking at in terms of statistics and prevalence rates? So in terms of general hospital environments, so med-surg, community hospitals, acute medicine, dementia is probably the most common mental health diagnosis that we're going to encounter. And like a lot of things, these statistics vary anywhere from 3% to 63%. And I think that variance probably has a lot to do with individual hospitals and the types of patients in their communities. For example, a hospital in Florida might be more likely to admit a higher percentage of older people than, say, a hospital in a rural area in Wyoming, for example. Major depression, though, is also quite common, 12% to 20%, 8% with any form of anxiety disorder, 5% with generalized anxiety disorder, and 3% with panic disorder. As you can imagine, rates of an acute depressive exacerbation go up at a time of inpatient medicine hospitalization, especially if it's an unplanned admission, understandably, because I've had a sudden medical event or sudden medical change, and that brings a lot of realities into sharp focus, which can be very troubling. So I think the first thing I want to talk about, and I do this with all kinds of, I train a lot of different kinds of students, physicians and nurses and chaplains, social workers, speech pathologists, and a place that I like to start sort of at the core of all of this when it comes to working with older people with dementia is a good inventory of ourselves. More than anything, more than any medicine or procedure or whatever we bring into the room, more than any of that, we bring ourselves. And I'm a big fan of encouraging people to consider throughout their career, as we change ourselves as human beings, what is it about an interaction or a relationship with me that is healing? Independent of anything I do or medicine I deliver or strategies I employ, separate from all of that, what is it about me? And so doing a good inventory of ourselves, I think, is vital. The biggest adversary I have come across in working with older people, and absolutely with older people with cognitive disorders, is ageism. And a brief history of this concept emerged in actually only as recently as 1969, which is within the lifespan, I suspect, of many of us. It did emerge, as you can imagine, from that time frame in the late 60s. It did emerge as an offshoot from the larger civil rights movement that was going on. The term was coined by Dr. Robert Butler, who was a physician, in a seminal piece. I'm glad to send that article along to anyone who's interested. But as the name would imply, we're talking about stereotyping, prejudice, discrimination against people based on their age. And it goes both directions, directed towards older people and directed towards younger people. And it can be both positive and negative. Speaking of older people, we have the image of the sweet old man, or the sweet old woman, or the quaint old woman who makes a lot of cookies, or the wise old man who's quite the sage. And those are beautiful images, and we've probably known people like that. But we also hear negative images, the cranky old man, the rigid older woman, the frail older person. And, again, we certainly know people who have medical frailties, but the trouble with this is that we miss the person. We reduce them to a stereotype, we reduce them to a straw person conceptualization, and we miss a lot in terms of their care, and it changes how we interact with them as providers. These prejudices start forming early in our lives as provider based on our own experiences with older people. They exist in a lot of different cultures and a lot of different countries. You will also, though, see a lot of different cultures that have a very honored stance towards their elders. American culture, not so much. But for those of us who do work, do a significant amount of work cross-culturally, it can be very, very encouraging to see the way some of our elders in other communities are treated and viewed. So we know that ageism directed towards older people has empirically demonstrated negative impacts on health and well-being. That's a 2-day seminar in and of itself, but I just want to summarize it here and say there are a lot of negative medical and mental health outcomes that come from being the target of ageism. So bottom line, it hurts people, it harms our patients, and it violates our most fundamental medical ethical precept, which is first do no harm, also known as maleficence. Also known as non-maleficence. Brief summary: increases risk for mortality, poor functional health, slower recovery from illness, and sort of overlapping a little bit with my social work colleague, increases risk for older adult abuse and elder neglect. Ageism among healthcare practitioners at all levels and among all disciplines creates a risk for substandard care, and it creates a risk for social exclusion and existential harm, including a loss of the will to live, separate from depression, more of an existential loss for the will to live. And my chaplain colleagues do a lot of work with this. Topic under the concept of ageism is dementiaism. This is a quote from JAMA, the American Journal of the American Medical Association, especially Journal on Ethics, from 2017. And I think it really says it all, especially in the US or in countries where mental health and cognitive issues are treated solely from a sort of clinical medical perspective. That perspective is vital. It has got to be at the table. But the model of care, the current model of care in dementia care is holistic. So it brings in mental health, psychosocial issues, spiritual issues, existential issues, occupational issues, etc. But if we write this, what they refer to as a tragedy discourse, emphasizing loss, that this is about loss, then what happens is, again, we inadvertently play into kind of an ageist narrative, and we wind up inadvertently creating harm above and beyond the challenges imposed on the person that comes from living with these illnesses in the first place. So, let me see, my slides have stopped advancing. There we go. So again, going back to the notion of an inpatient admission as a bridge, this is, I like to think of this as an opportunity to consider our perspective. We communicate a lot. We teach a lot to families, caregivers, and patients without even realizing it. We can't help but do it. Even if we're not saying anything, we're saying something. So remember, we're the experts from nursing, medicine, social work, chaplaincy, rehabilitation therapies, you name it, case management. We're the experts. We're who they're looking to. So an admission can be an opportunity to identify unidentified cognitive issues or etiologies. A person's cognition may have declined in the last year or two since the diagnosis was made, and that may have contributed to why they are admitted now. So this is good. This is a chance to find that out and help return them home with some added resources. There may be new etiologies. I've seen many cases where a person with Alzheimer's comes in, we're detecting some changes. The course and nature of the changes isn't consistent with just Alzheimer's disease. We get a good set of head imaging and find out that the person has had small strokes that no one knew about that were silent. So we need to attend to that. As my social work colleague mentioned, an opportunity to identify longer-term care needs that may not have been recognized, for example, with functional changes. And so now we need to provide Meals on Wheels or other sorts of OT and home evaluations to make up for functional changes. And you'll hear as I go throughout this, I'm going to keep referencing all of these other disciplines because, and I know I'm hitting themes that you've probably and will hear in other places across the day, but that is because they are so fundamental and they're so foundational that we want everyone to be attuned to them. We want everyone to be aware so that we can all raise an issue. Because, in the Venn diagram, each of us has our unique circles that we cover, but we're talking about issues which are in the center that we all can address and be aware of, and then make sure the proper colleagues are aware of it. So, as I alluded to, an inpatient admission can also be an opportunity to identify unrecognized medical issues, medication issues, an opportunity to provide that close-in care for caregivers or spouses or loved ones, friends who may have become overwhelmed. You may have a caregiver who's in acute caregiver burnout, and this is an opportunity to get in there with them too, and to help educate. Some of the best training that I've seen happen in our inpatient unit is when our nurses help train, say, for example, a spouse who's going to be taking their spouse home after a respite stay, and that spouse gets some great training from staff in OT, PT, nursing, etc. So it's really, I almost think of it in a way kind of as a training camp, or it can be like a boot camp for the caregiver. And as I mentioned, that failure narrative, going back to the quote from the JAMA journal, ethics journal, this failure narrative from us can highlight and exacerbate any feelings that are already going on along this line with the patient and with those who love them, because they may already be in that kind of mindset. And if we're fostering that further with our own perspectives, then we cause more problems than we solve. So, but inpatient admission is not a panacea. We know that hospitalization for people with dementia commonly leads to an increase in what are called the BPSD, or the behavioral psychological symptoms of dementia, can exacerbate cognitive problems. In a study of 10,000 hospital admissions throughout the country, the authors found that among people with a dementia diagnosis, delirium flared up in about 46% of those people during the hospital stay. This is going to certainly complicate medical care. Going into a hospital in and of itself can precipitate a delirium, but certainly common reasons a person might be hospitalized, for example, pneumonia, sepsis, things like that, carry a risk of delirium as well. But it's often not caught, and I'll talk about that more in a second. We know that consequences for people with dementia who are admitted for acute hospitalization include higher mortality risk, falling in the hospital, additional functional decline, disorientation, cessation of eating and drinking, taking fluids, unnecessary increased reliance on caregivers. So my ADLs may well drop away. And certainly this could be the result of illness, but it can also be the risk of being in an unfamiliar circumstance and not knowing anymore how to do the things that I used to know how to do because they're so situationally bound. I could do them at home, but I can't do them here because this is a different place. And I mentioned depression and delirium. Additionally, on a real practical level, a person with dementia can experience more pain, thirst, fear, higher risk of overstimulation than people without dementia who are in the hospital. And again, in part because of reduced ability to communicate. And I want to bring our speech pathology colleagues in here as well. Partnering with those folks is pivotal when it comes to dementia care. I like to conceptualize the two key human psychological needs as the ability to speak and the ability to be heard. So from the more popular literature, I like to take things sometimes out of the academic perspective. What struck me is that the author of this quote is himself a geriatrician at the University of Pennsylvania. But he's talking about having a dear uncle who was admitted to the hospital, and his uncle has dementia. And he's saying, I'm not trying to say that my uncle is a child. He's not. And that actually speaks to the ageism piece. You'll hear sometimes what's referred to even as elder speak that gets used with older people. And this is that very sing-song type of speech that's used with children. And you'll hear it get used with younger people, including words like sweetie and honey and things like that. So he's saying my uncle's not a child, he's an adult with a very long history, a very potent man. And yet the author's saying as a physician, he knows that if his uncle is admitted to the hospital, his ability to function on his own is in real jeopardy. So, and I've seen it countless times. I've seen any number of people from profoundly powerful histories who in an inpatient setting struggle, especially in the context of neurocognitive disorder. So we need our caregivers. We need people who are familiar with us. And we need, as a staff, to understand our role as caregivers. And that includes how we interact individually, which I'll talk more in a second, but it also includes the kind of environment that we create for people with dementia. And Kit Wood is an author who I like to cite a lot, and he wrote about what he referred to as the malignant social psychology in dementia care units. I mean, he was speaking specifically about inpatient dementia care units, but it can easily be extrapolated to any environment in which a person with cognitive disorder is receiving care. And his system is one of those that's it's pretty self-explanatory when you see it written out like this, but unless you know what you're looking for, it can just feel wrong, but you can't really put a finger on it when you're in it. And so I appreciate his system here because it allows me, when I'm in a setting, I'm working with a person who has cognitive disorders and, for example, maybe having behavioral issues, it helps me put a finger on what's happening that may be triggering that. So as you see, an example of toxic dynamics, and if you think about common inpatient units, especially acute units, you can see how easy it is inadvertently for the environment itself to elicit some of these factors. For example, disempowerment, resulting from that infantilization, being outpaced. Acute units are usually pretty fast-paced, lots of people in and out, lots of things happening. Hopefully not some of these other things, the mocking, the stigmatization, feeling ignored. But inadvertently, again, on a busy acute unit, especially if someone is having, heaven forbid, a medical crisis, then other patients may not be attended to as quickly as they otherwise would be. Um, on the other side, health promoting, and these are essentially just the other side of the coin, in terms of the person with cognitive disorders feeling validated, recognized, having some role in the care processes and when those things are carried out, helping them fit as well as possible within the routines that are understandable and consistent for the person with cognitive disorders. So next slide. And I'm going to try to move my bar here. There we go. So I like this review. What are the needs of people with dementia in acute hospital settings? What interventions are made to meet these needs? A systematic systematic integrative review of the literature. So I found this article and I thought, this is it. This is perfect. It's exactly what I want to talk about. Moving out of Kitwood's work, people may not realize it, but there's a whole specialty in interior design and building design that has to do with designing hospitals and structures that are going to be involved with taking care of people, medical settings. And so they specialize in designing environments, literal physical environments that are friendly, so to speak, for, in this case, for people with cognitive disorders and dementias. So literally an environment that enables as much independence as is safe for the person with dementia, that and accomplishes this by making it feasible and reasonable for the person to navigate their surroundings as much as possible. A big reason for this is so that the person can independently seek access to other people. So if I am an older person with dementia, cognitive issues, and I'm in the hospital and I'm confused, it's helpful for me, if it's safe, to be able to walk out to the nurse's station and ask my question or ask for help. I'm less likely to become agitated and confused, lying in the bed, helpless. But also, it's an environment that hopefully facilitates my ability to seek quiet if I'm overstimulated. So if I'm sitting in a common area watching TV and I'm overstimulated, hopefully I'm able to safely remove myself back to my room so that I can find some peace and quiet. Specifically though, putting the rubber on the road, the physical environment, because it can be so chaotic, again, means that ideally the area around me will be as quiet and simplified as possible. So in other words, removing unnecessary equipment from my room, ideally not having the television on unless I want to watch it, ideally knocking quietly before coming in the room, not just entering the room, things along those lines. And to help me find my room, if I need to go there, taking special care to identify my door. So rather than just having my name on it, that certainly can be helpful. But for example, to have a picture on the door that's meaningful for me. So for example, we've used, most recently, we had a veteran who was Puerto Rican, and that his culture was understandably very important with him and for him. And so with his agreement and his family's agreement, we posted a Puerto Rican flag, picture of one on the door to his room, and that helped him with wayfinding. Lighting is very important. Dark areas, glare on the floor can increase the risk of falling, as well as exacerbating confusion and psychosis, actually. People with advanced cognitive disorders do sometimes hallucinate, and shadows or unclear visual percepts can trigger hallucinations. And I mentioned important to try to, at least in my space, keep equipment and things like that that are unnecessary out of the way and out of that setting. And also because these things can make it hard literally to use things like handrails as I try to navigate down the hallway. Gosh, let me try this. For whatever reason, there we go. My computer is having difficulty responding for whatever reason to advancing the slide, so I apologize for that. So how do we get started in this? First step, get to know who is the person the disease has. Who is the person who has gone on to develop this cognitive disorder? And this is what's referred to as person-centered assessment. I cannot emphasize enough the importance of issues of human diversity that come into all of this, especially with older people and the history that they've lived through. It's not uncommon to find people, whether they are Black, Indigenous, women, LGBTQAI, any of those communities who may have a mistrust of the dominant culture and the medical care system. Vital to incorporate that. They may have a history of pathologizing experiences in the medical system, interacting with spiritual variables there. The most recent situation like this that I worked was helping differentiate some beliefs in a person between psychosis. His spiritual beliefs were being mislabeled as psychosis, when in fact, after consulting with a knowledgeable pastoral care provider in his denomination, we determined that they were actually quite consistent with his faith tradition. And so it was very important for the team to understand that this was not psychosis. We should not pathologize this person's spiritual faith. But other variables come in here. Socioeconomic status. A person may have been homeless. We see a lot of people who have been unhoused, who are admitted and don't know how do you be in a hospital environment, don't understand how that works. And I mentioned ageism and dementiaism there. So this actually, the quote up top here, this is from one of my notes. And I wrote it and looked at it and I thought, wow, that is really clinical, but that's how we write. And that's kind of what got me interested in person-centered assessment, because especially with people with dementia, and especially for those who can't really tell you who they are, it is awfully easy for them to disappear into a note like this. So I encourage us, especially, any of us, no matter our discipline, just to talk to the person non-clinically, 2-3 minutes. How are you? What brings you in today? Where did you come in from? See what they know, see what they understand about where they are. What do they like? Pick up on small things. If they're wearing a t-shirt with a football team on it. So are you a Kansas City Chiefs fan? Yeah. And talk about football with them. Do you ever play football? Little things, small things that help you get to know the person. I like a deep chart review, and what that means is going all the way back to the first notes that you can find and reading about the person, because those were being written at a time when who that person, the life they lived prior to becoming ill, was most proximal, and you'll probably find the most detail there. Interviewing the family, of course, reading up on the history of their times. It can be very important. I tell students, for example, to work in geriatrics, you kind of have to be an amateur historian. So if you have someone who lived through the Great Depression or who fought in the Tet Offensive and you don't know what those things are, look them up, because it'll tell you a lot about that person. We're all a product of our times. And quietly observe their daily rhythms when they're on the unit. Do they get up early? Are they getting up as the night shift is going off, at 5 or 5:30 in the morning? And we notice he's doing that. I wonder if he's typically an early riser. That's important to know, because if I'm not, that's important to know too, because we need to find out why I'm getting up at 5:30 in the morning when I don't normally do that. Bring our speech pathology colleagues in again. We want to look at communication abilities. For example, aphasia, Alzheimer's disease and aphasia go hand in hand, but certainly aphasia exists in other forms of cognitive disorder. For example, someone who's had a left middle cerebral artery stroke, also right, but definitely a left middle cerebral artery stroke could have profound language loss and speech difficulties. So we want to know, how does this person communicate? How can we best communicate with them so that we don't outpace them? Slowed central processing speed, which is very common in cognitive disorders, especially with vascular cognitive disorders. So again, how fast do they understand what we're saying, and how quickly can they process what we're saying and what we're asking them to do? Visual and hearing limits. Did they remember to bring their hearing aids or their glasses when they came to the hospital? If it was an acute, unexpected admission, they may not have, and that's important to know. I cannot emphasize enough getting information about their pre-admission cognitive baseline. On the one hand, we can easily miss a delirium, which I alluded to earlier, by just assuming, oh, the person has Alzheimer's disease, that's why they're like this. This delirium come in different sorts, but especially what's referred to as a hypoactive delirium. Going back to the Wheel of Fortune question on the 3Ds, dementia, depression, delirium, a hypoactive delirium is at high risk for being misread as dementia and also as a depressive episode. And the concern there being that delirium can be lethal if the cause isn't detected and dealt with. On the other side, I've had to evaluate people who came out of an inpatient admission with a diagnosis of dementia who didn't have it when they went in. And I've had to do the clinical evaluation to reverse that, because what happened is the person had, say, they were septic, had a delirium in the hospital and were misdiagnosed with dementia because the hospital staff didn't find out about their pre-morbid cognitive level. So find out pre-admission routines, likes, dislikes, what soothes the person, what helps get them in a better frame of mind, what are some healthy distractions, how well do they tolerate relationships with others, especially new people. There's a lot of information, again, a whole other talk on attachment patterns, adult attachment patterns in people with dementias and how that plays out. For example, in my ability to develop a rapport with nurses who I don't know. I may be pretty good at that. I may have been a pretty sociable person and it works, or I may not have, and I may struggle to develop relationships. And so it's important for the staff to know that so they can help me with that. And what's my prior experience with hospitalization? Was it very traumatic? A delirium, for example, can be very frightening. And if I was admitted with pneumonia and a significant delirium, all I may remember is that hospitalization was very, very frightening for me. I may have a lot of very bad memories. Or, I may have appreciated every time I've been here, the staff have been so nice. Important stuff to know. We want to also look at decision-making very actively. As my social work colleague mentioned, older people, especially post-op, like a THR, things like that, are at high risk for delirium, for post-op delirium. Central anesthesia can have significant and sometimes irreversible effects on cognitive status, but certainly temporary effects. And then especially if this is superimposed on a person with cognitive deficits, I'm at high risk for my decision-making capacities to be impaired. This at a time when the stakes are so high, for example, care planning to go home, or things along those lines. And so really important to get a sense of how well I'm making decisions and how able I am. And again, this can get missed, especially for people with milder or more moderate stage neurocognitive disorders, because the fact that I have cognitive limits may not be so grossly evident as they would be, say, for example, if I had advanced Alzheimer's disease. So one of the biggest things I coach students on is never forget to talk to the patient. Never forget to talk to the person and listen to what they have to say. These are things that have actually been said to me over the years working with patients with cognitive disorders. A person who looked at me and said, I'm looking at your face to know that if it's okay. He had enough retained insight to understand that his brain wasn't working, and he talked with me a lot about his subjective experience of not being able to get his brain to do the things it used to be able to do. And he looked at me one day and said, Doc, I'm looking at your face to know that if it's okay. In other words, he was looking to me to know that I was there. I got you. I got your back. You know, I'm here with you. We're going to work through this together. So relationships matter. The next quote was from someone who actually wrote this to me. The language was a little jumbled. I've corrected the syntax and the spelling here. But again, retained insight, understanding that something is going wrong, but I need you to know that I'm still here, even though my memory isn't so good. Same person. I went on the unit one day to see him, and he said, I'm afraid they're mad at me here. And I said, I don't think, I'm not aware that anybody's mad at you. I don't think you did anything wrong. And he said, just because they're mad at you doesn't mean you did anything wrong. And I thought that was really profound. And I was having a really hard day that day. And that actually turned out to be a little psychotherapeutic moment for me. But it told me he has his own opinions. Just because I have a cognitive disorder doesn't mean that I don't have my own ideas and my own thoughts about things, including my own care. And the last one was from a guy who he got upset every time the nurses came to use a Hoyer lift with him. And I sat down with him one day and I got a Hoyer lift and brought it over. And I just kind of scratched my head and I said, do you know what that contraption is? What that's for? It's kind of confusing. And he said, yeah, they use that to put you on horses. And I hate horses. And so it just spoke to me about, again, his perspective. What was his perspective about what was happening? So these are just some questions we can use to talk with a person with dementia to get a sense of their perspective. And I like to just sit down side by side and say, hey, how are you? Introduce myself. Very conversational. The last thing I want to do is go in, so to speak, figuratively with a clipboard in my hand, asking questions. So it's all very conversational, but again, it's a way to get at this person's perspective. So some team strategies, if possible, talk about the hospitalization in advance, include the person with cognitive disorders in the planning. What will you need? What do you think about it? And that's not always possible, but if it is, it can be important to do that. A private room can be very important with facilities for the caregiver or someone close to the person to stay with them. Bring in some mementos, bring in some activities from home that I enjoy, just to help me pass the time. Assume that I'm going to have trouble operating some of these common, hospital room pieces of equipment and accommodate for that. Bring in OT, PT, etc., and help me accommodate for those things. As has already been said, don't do the foot of the bed thing, which is where staff are talking about me standing at the foot of my bed and I'm kind of just there. It's the most common thing that leads to that feeling of disempowerment and infantilization that we saw in Kit Wood's scheme of things. Target your questions to things I can answer. This is part of creating an environment in which I feel included, but also not creating one in which I feel outpaced or left behind or caught out, spotlighted for the fact that I have memory disorders. I know sometimes that I can't answer a question and it's humiliating. So set me up for success might be another way of saying that, and including me in a way that I can succeed. And have a family member stay with me. We mentioned that, but especially during medical tests. There may be some things that I'm not able to tolerate. So for example, a CT scan. CT scanners can be frightening, especially an MRI scanner can be extra frightening. Blood draws, you name it. Have someone sit with me who knows me while this is going on to help me tolerate that process. Liberal reorientation. I coach nurses, for example, every time you go in the room. Hi, I'm Steve. I'm a nurse here. It's good to see you again. It's a beautiful day out there. I hope you're enjoying it. Hey, the reason that I'm here is to help change that dressing. How do you feel about doing that now? This thing on your knee here. Um, so lots of reorientation to person, place, task, all of those things. And again, giving choices whenever possible. Um, Hardware like clocks, written schedules, names of staff and their key roles. You know, your doctor is Dr. Melendez, for example. And similarly, a schedule, you know, occupational therapy will be here today at 1 to help with learning to use so-and-so. So a lot of specifics that are written down to help me best understand what's happening to me. If possible, a proposed sense of my discharge date. Nothing's ever set in stone in a hospital, but if it's possible to give me a sense of, you know, you will go home on X date and mark it on the calendar. I mentioned lots of reorientation to who we are. Important to remember someone who's significantly disoriented may have no idea where they are, who we are, and not be able to maintain it. You know, they may remember for a minute or two. They may not even be able to remember it for the course of a procedure. If that procedure takes 20 or 30 minutes, they may not even be able to remember what's happening for that long. And so we may need to provide the reorientation again and again, even within the span of a single contact. I use the metaphor, if you can imagine being transported, blindfolded and transported somewhere that you don't recognize, surrounded by people that you don't know, and then one of them comes over and tries to take your clothes off and clean you up in very private areas. Imagine how we would react. It's no different for a person with cognitive disorder. Slow down our approach, try not to rush. I mentioned being conversational, collaborative, friendly, all of those things, and use redirect and reapproach when possible. My nursing colleagues will recognize those terms. If it doesn't have to be done right now, and I'm upset about it, I'm uncomfortable, I'm confused, don't do it. Help me calm down, talk about some other things, give me a 10-minute break, and then try to come back and do it again. Odds are I'll be ready by then. So use soothing music, especially comforting rituals, especially during care. So turn my music on while you're changing my dressing. Lots of other activities can be great. Reading, faith practices like prayer, singing, reminiscence, all of these things can help reduce boredom. Hospital volunteers are wonderful for this, for taking time with me and doing these things with me. Be careful about TV shows. Even if I have advanced illness, I'm still going to be able to pick up on the affective tone of things like shoot 'em up cop shows, or talk shows where people are getting very upset. So be careful with those things, and thoughtful. Sometimes it can be helpful to remove street clothes from sight. This can help reduce wandering or elopement risk because they can be a trigger that I'm supposed to put those on and go somewhere, because that's when I put those on. Put lots of cues around where the bathroom is. Again, I mentioned something on the door to my room that tells me where that is. Cues that tell me where the call light is and what it is, things like that. And replicate my home routines as much as possible. So if I usually don't eat breakfast, but I eat lunch, okay, let's do that. Don't try to force me to eat, you know, a meal that I don't normally eat. So last couple of slides, just a couple of models that we use when we're trying to understand, piece together, you know, a difficult behavioral challenge that may have emerged when we're in the hospital. One way to look at it is, it's called the ABC model, the activator behavior consequence model. Again, you know, it's not rocket science, but having this model can allow us to use, like Kitwood's model, it can allow us to have a frame of reference to begin to parse apart something that we're seeing that seems really complex. And can be a way to break it down into its constituent parts. So we start with the B. What's the behavior? And we really get specific about defining it. So it's not just, for example, agitation. Well, that's helpful, but let's break it down. What does it look like? Well, pacing. Okay, sure. Pacing, and not just pacing, but with a concern, kind of an angst look on my face and wringing my hands. Okay, beautiful. Now I know what we're looking at. When does it happen? How often does it happen? Pretty much every day. How long does it last? Gosh, 30 minutes, an hour, unless someone goes in and actually does something about it. I don't seem able to stop it on my own. How intense is it? Well, it seems pretty intense just based on how fast I'm pacing. Just my face is all kind of screwed up and looks concerned. Okay, so that gives us a much better description of the behavior. So now we jump to the A. What are the potential activators? Who are the people that are around? Who just came in? Who just left? Not that they did anything wrong at all. In fact, what I'm reacting to may be the fact that I'm very attached to them and they just left. So for example, a nurse that does a really good job with me was in for a while and just left. And now I'm reacting to that person's absence. Where is it happening? Well, it happens in his room, but it seems like he's okay when he's out of his room around other people. Aha. Okay, I'll talk to that in a second. What kind of things are around? Maybe medical equipment, and I don't know what it is. Maybe a Hoyer lift, going back to my example. Events that were going on, or absence thereof. Yeah, it was between lunch and dinner, and things were, there really wasn't a lot going on. And what time of day? Might be in the evening, when I'm tired and my brain is tired, and maybe I'm vulnerable to being more confused in the evening. A lot of us have seen that phenomenon. So then we look at the consequences, the outcome of the behavior. So what happened? So for example, I got agitated. I started pacing and got agitated, and staff responded, and then I calmed down. That's good. Staff did the right thing. But the fact that it went that way can tell us something about what might be causing my agitation, which I'll speak to here in a second. Did it obtain something? Did the behavior obtain something that I might need? Did it allow me to avoid something? I got agitated, and so as a result, something that I was very afraid of didn't happen, or didn't understand didn't happen. So one model, though, and as I mentioned, I'll get into this in some more detail now, it overlaps very neatly with the second model, which is the unmet needs model. And this essentially says that a challenging behavior that's an issue, may be a way to communicate an unmet need. I may be becoming upset, and clearly that's a problem for me. I'm upset, I'm distressed, but what am I trying to say by that? And especially if I have an aphasia and I can't speak very well, all I may be able to do is become agitated. So those needs can include anything from physical comfort to pain, hunger, thirst, too hot, too cold, akathisia, depending on medications that are involved, a need to move, just stiffness, overall stiffness, restlessness, understimulation, overstimulation. Going back to my brief example, I may be missing social contact. I may be feeling lonely and anxious. And that's why I'm calmer when I'm out in the common area than I am when I'm in my room alone. Or why when I get agitated and staff respond, I calm down because I don't feel alone and afraid anymore. Or when I'm feeling infantilized, if people are having a conversation at the foot of my bed, and I'm looking more and more uncomfortable, because even if my illness is advanced, I can tell I'm being talked about. So what do? We address the need. We figure out what the need is, and then we address that. And especially if we have to read between the lines, sometimes it's trial and error, but that's okay. we usually find our way to the right solution for that individual. A quick word about antipsychotic medications. Neither conventional nor atypical antipsychotics are the be-all, end-all, go-to no matter what for challenging behavioral related concerns in cognitive disorders. Most of us are probably aware there's an FDA black box warning on those things with an increased risk of death for older people with dementia. That's why regulating bodies, for example, when our nursing facility is inspected, the first thing they look for is use of antipsychotics, and when are you using them and when are you not using them, and to make sure that those are being done, managed correctly. So non-pharmacologic interventions are the first line, unless, now I'm a big believer in salt and pepper. And so the best outcomes I've seen are when medications, for example, antidepressants, other types of psychotropic medications are used in conjunction with non-pharmacologic mechanisms to address a concern. You get a nice synergy there sometimes. I'm speaking specifically though to antipsychotics, especially in that realm. Non-pharmacologic interventions are the first line, and we are expected to follow that standard of care. Unless there is an immediate threat to safety, well-being, agitation, aggression, psychotic symptoms that are very distressing, for example, frightening hallucinations, things along those lines. Antipsychotics should not be used for things like wandering, mild anxiety, uncooperativeness without aggression, apathy, other behavior that is troubling, but not aggressive or posing an immediate risk. So again, non-pharm mechanisms are where you want to go there. As I mentioned, I'm a psychologist. My board certification is in geriatric psychology. We are out there, and certainly serve as a resource when it comes to non-pharm interventions. That's one of the things that we're there to consult on in organizations. So just some resources here, and these are for us as staff. These are for families, in terms of partnering up and anticipating and helping for best outcome for a person with dementia who is hospitalized.